Is it audible now? Is it clear? Yes. Okay. Can we start? Okay. Yeah. Nice. So, welcome to our channel. Today we'll be seeing some important aspects in ECG of myocardial infarction, and after seeing an ECG, how to predict the prognosis of a patient, of what prognosis he might end into, and how to take decisions, treatment decisions. Okay, and also how to manage the diagnostic dilemmas which usually happen in clinics. Okay, yes. So actually, we have made one introductory video of this direction of death, meaning how the ECG changes have resulted, and what clues ECG gives before a complete myocardial infarction ensures. Okay, so yes, so this is the normal ECG. As we told, this is the Q wave. Q wave corresponds to ventricular depolarization, QRS, and this is ST segment. In ST segment, ventricles will be completely depolarized, no extra current will be going on, and this is T wave, which corresponds to repolarization of the ventricles. Okay, so what happens in ischemic heart disease is, first the ECG will give you a clue. What is the clue? First, T wave change will occur. See, here the artery is getting moderately obstructed. First ECG change will be reflected in T wave. That is ischemia. So, this T wave changes in ECG is very important in predicting the development of MI in future. Okay. Next, we saw about this ST segment changes will manifest if this ischemia is not at all seen. Then this will manifest due to complete obstruction of coronary artery, that we see as ST elevation MI or ST depression, leading to end-stage non-ST elevation MI. Then, if you don't care, don't treat the patient, then it will result in Q wave changes. So there, the injured myocardium is completely replaced by scar tissue, non-contractile, just fibrous tissue. So that we call it as infarct. This is injury. Everyone able to follow? So, can someone say, yeah, okay. So, can someone say, what is essential in diagnosis of MI? Whether it is ECG change, or is it cardiac biomarker elevations needed, or is it echo change? What is the essential criteria in definition of MI? Okay, to diagnose MI? Yes, good. Surya Prabha, Ganesh Kumar. It is biomarkers are essential than these changes. You can't expect echo changes to be in all cases of infarction. At the same time, you can't expect ECG changes also in all cases of infarction. But the essential criteria is positivity of cardiac biomarkers. Okay, this will be seen in subsequent sections just to reinforce this concept. Yeah, so what will be our goal? Our goal is just to reverse this direction. Like if some Q waves are present, our aim is to convert this into this portion, and if ST segment portions are there, then we should convert the changes into this area. Then it should be reversed into normal ECG. This will be our goal, and this will be the normal development of MI. Okay, this is the normal direction changes with respect to MI development. So can I proceed further? Yeah, this was actually we discussed this in previous sections. I have discussed an introductory video on T wave changes in myocardial infarction, that ischemia. Okay, T wave inversions will happen in case of ischemia. Okay, we have discussed the mechanism also for that, how it happens. So how it happens is actually what happens here is ischemia. Hello. Is it audible? Yeah. So it is, this layer is known as subendocardial myocardium. Okay. Actually, if you see, this layer is more susceptible to ischemia because the layer of myocardium here, which is subepicardial layer, and this myocardial layer will get direct blood supply from the coronary arteries, which are penetrating from outside. But this layer can't get, it's a distalmost portion. So whenever ischemia is there, the first pass to get affected is subendocardial myocardium. Okay, yes. So if that is affected, it will manifest as, see, first subendocardial myocardium is affected. So what happens? This is a written rule that any ischemic cell will depolarize very fast. Okay, and so if depolarization has happened means it will be followed by, yes, repolarization. So repolarization will be in this direction, from subendocardial to the epicardial region. So that means normal direction of repolarization was apex to the base. But here what happens? It is happening in the opposite, reverse direction. So normal T wave should be like this. Since it happens in the reverse direction, there is T wave inversions. This is a finding in ischemia. If you find it earlier though, we can prevent the patient going into infarction. Okay, yes. The other cause of T wave inversions I have discussed in the video. Just go and look into it. Okay, now we can go for next state. What is the state? Injury. Okay, injury. So what happens in injury? Can someone say what happens in injury? What happens to the coronary blood flow? Yeah, it is stopped, meaning it is completely obstructed. Okay, it is completely obstructed, which we call it as critical occlusion. Meaning, what happens is, yes, good, Sachu, Ganesh Kumar. So what happens is, this coronary artery is completely obstructed, leading to complete reduction in blood flow. So what happens? We have studied like decrease in blood flow or complete stoppage of blood flow. What will cells? What will happen to the cells? Cells will undergo. What is the pathology first chapter? necrosis. Good. So, if cell starts undergoing necrosis, no energy is delivered to the cell. Yes, Ganesh Kumar, it is sodium potassium ATPase is present in the cell, needs ATP for their pump running of this pump. So, these pumps won't run efficiently. So, what will happen? Sodium potassium ATPase will pump out sodium and will take in potassium. But this won't happen here. So, what will start to accumulate? Potassium can't enter into the cell, so potassium accumulates outside the cell. So actually what's happening here? Local hyperkalemia is going on. Okay, now can someone say in hyperkalemia, what is the T wave change we will be expecting? What is the T wave change in hyperkalemia? Come on. Come on, start answering. Good, Ganesh Kumar. Tall T waves. Okay. It will be a tall T wave. Good. Surya Prabha, Sachu Prasad. Good. It's a tall T wave. So, actually, if you see, this local hyperkalemia also is present around the heart. So, it mimics hyperkalemia. So, there will be also a tall T wave present in MI. Okay, there will be also a tall T wave present in MI. But this tall T wave will be difference between hyperkalemic tall T wave as well as So, if you find a tall T wave, what you should see? Actually, if you see a T wave, it will be generally asymmetrical. Meaning, see this. If you divide the T wave into half, it won't look exactly same. This is normal asymmetric nature of a T wave. But if it is symmetric, then two differentials will be MI or hyperkalemia. So how to differentiate that? Just with an ECG? Yes, as Ganesh Kumar and Sachu Prasad is saying, MI may what happens is there will be a broad base with a blunt tip. Both are BB. MI. Blunt tip as well as broad base. But in hyperkalemia, you can keep mnemonic like this. Hyperkalemia, if you see, K is like this only, na? So, pointed tip with a narrow base. Narrow base and a pointed tip corresponds to hyperkalemia, and broad base and blunt tip corresponds to MI. Okay, so both will have tall T waves. And in MI, if you see, the QT interval will be prolonged. But in hyperkalemia, if you see, the QT interval will be depressed. And one more interesting fact you should know here. Here in MI, as we know, ST elevations can be there. At the same time, in hyperkalemia also, ST elevations might happen. So you can see how closely hyperkalemia mimics MI. Okay, ST elevation can be there and tall T waves can be there. But our aim to see the morphology of the T wave, how the morphology of T wave is there, and to calculate the QT interval, and if MI is there, cardiac biomarkers will be positive as we saw initially, and if potassium is elevated, then serum electrolytes, if you do, potassium is elevated. So these are differentiation point, how to differentiate MI and hyperkalemia just with the tall T wave. Got it? Can I move forward? So, this tall T wave, actually if you see, this tall T wave is the earliest finding. Earliest ECG finding in case of what? Injury or myocardial infarction. Earliest finding will be tall T wave, and this will last only few minutes. This is very difficult to find a patient with tall T waves, because when the patient presents though, he will have the next changes, like ST changes will be there. Okay, but if you find tall T waves, so it is earliest feature of myocardial infarction. Injury is started to happen. Okay. Yes. So next, see this picture. What is this picture? This is the picture of a myocardial cell. Okay. Okay, can someone say what are the types of troponins in a myocardial cell? What are the types of troponins in a myocardial cell? Come on, be interactive. What are the types of troponins? Yes, troponin C, good. Surya Prabha. Ganesh Kumar, good. C, I and T. Yeah. Yeah, troponin C, T as well as I is there. Nice. So, what happens is, since injury is going on, the cell is undergoing necrosis, meaning what's happening there? The cell is getting damaged. Cell membranes are getting lysed. See this. Cells are getting necrosed. So what will happen? All contents present inside the cytoplasm of the cell will extravasate into the bloodstream. What are the enzymes present in a heart myocardial cell? CPKMB. Creatinine kinase, MB fraction. Yes, good. LDH1. LDH is a enzyme present in a myocardial cell. Actually, if you see, good evening, Nimati. Actually, if you see, LDH1 and LDH2, you should know something. Usually, mathematically, 2 is greater than 1. So, normally if you see, LDH2 is greater than LDH1. Because LDH1 is normally present inside the cardiac cells. So, if necrosis happens, the LDH1 starts to enter the bloodstream, increases in the bloodstream. So, now if you see the fraction, what will happen? LDH1 becomes greater than LDH2. Okay. So, this phenomenon is known as LDH flip. That is flipping of this. 2 actually was greater than 1. Since this LDH1 was within the myocardial cell, since necrosis has started, this LDH1 went into the bloodstream and this fraction has increased more than 2. So that is LDH flip mechanism. It's the most important question. Actually, it was asked in NEET PG. Okay, good. So LDH we discussed, CPKMB we discussed. Then what is the other? Contractile proteins. As we told, myosins, troponins. Troponins, if you see carefully, troponins we have types as Surya Prabha and Ganesh Kumar told, C, I and T. Okay. Yes. So, do you know what are the troponin kits we use normally? Usually the troponin kits we use will consist of trop T. They will call it as trop T or trop I. Okay. Actually, if you ask me what is most specific to the heart, it is troponin I. Among the troponins, most specific is troponin I. Okay. Troponin T is okay, but still troponin I is the best marker among troponins. And actually, this troponin T now, it gets excreted in the kidney. Excreted via kidney. So, what happens is, in cases of chronic kidney diseases or the patients having diabetic nephropathy, can the troponin T can it be excreted in urine? So, what might happen there in such patients? If CKD patient or diabetic nephropathy patient comes to you complaining of chest pain, you do troponin T. What might happen in such patients if you do troponin T? Can someone answer? Whether it will be, whether trop T will be elevated or trop T will be reduced. Yeah, why is it elevated? Yeah, good. Ganesh Kumar. It is due to decreased clearance. The troponin Tn is not filtered and expelled by the kidney, so troponin will accumulate in the blood. So it will show false positivity in cases of kidney problems like CKD, chronic kidney disease patient or diabetic nephropathy patients. Okay, so in such cases, what troponins you should use? Troponin I is the troponin of choice in case of CKD patients as well as diabetic nephropathy patients. Okay, this is with respect to cardiac markers. So still the cell is lysed. We saw the three cardiac markers LDH1, CPKMB and troponins. Among troponins we saw troponin I as well as T, most specific of troponin I, and we saw what is the importance of troponin T getting excreted by the kidney. Okay, yes, nice. So now we will move on. Then I wanted to say some more thing. Like see here, what happens is, since the cell is completely injured, normally depolarization and repolarization will be happening in the heart. Now since the cell membrane is damaged, what will happen though? All the positive ions starts coming into the cell because the gate is open, all channels are open. Since all the membrane is completely lost, all potassium positive ions like sodium, potassium all starts pouring into the cell. It's nothing but this that injured cell becomes like a dustbin for all positive ions to pour into the cell continuously. Sodium, potassium, yes, it's like a positive ion dustbins. All positive ions start pouring into the cell. See, all get start pouring into the cell. Okay, so with this, what can I understand? See, normally this is a normal wave P, QRS, T. So if there is a subendocardial injury going on, I am saying injury. First we saw ischemia. This is injury meaning complete obstruction. So at this time also, cell membrane will be damaged. All cations starts to pour into the cell. So we know in ST segment time, no current flow will be there because ventricles will be completely depolarized. No active current flow will be there. Since this area has become as a cationic dustbin, so all cations starts to pour into the ischemic, injured cells, even in timing of ST segments. So what will happen to the ST segment? See, so all current is moving towards the subendocardial region. So that means it is going in this direction. So leads placed here some depolarization wave going away from a lead. It will record as positive wave or negative wave. Depolarization wave going away from a lead. Positive or negative? Yes. So it is negative wave. So that happens to the ST segment here. ST segment starts to get depressed. Okay. This is the reason of ST depression. Good, Suvalakshmi. ST depression in ECG. Good, Sach Prasad. ST depression ECG, this is the mechanism why ST depression happens. So at this time, you measure the cardiac troponins. Good, Kartika Shiva. Cardiac biomarkers you measure like troponins, CPKMB. If it is negative, what is the diagnosis we give? And if it is positive, what is the diagnosis we give? What is called, come on, if it is negative, what we will call that diagnosis, and if it is positive, what we will call the diagnosis? Can someone answer this? Good, Surya Prabha. Elevated, okay. What is the term given to that? Okay, I'll give one more clue. What we will call it as unstable angina, and what we will call it as NSTEMI. In this two, what is unstable angina? What is NSTEMI? Now, can you guess? Come on, start guessing. Yes. So, unstable angina, if cardiac biomarkers we see na, if it is negative, we call that condition as unstable angina. Okay. If these biomarkers are positive, then we call it as unstable. Good. Kartika Shiva, Ganesh Kumar. Okay. Yes. So this was the question asked in INECT. SD depression with PV inversions they asked. This was the patient, or if the patient had cardiomyopathy positive, then it is NSTEMI. Okay. Okay. Then you should know what are the types of good. What are the types of ST depressions? See, actually, if you see, ST depression starts like this only. The ST segment, usually if you see, ST segment will be like a curve. This point will be like a curve and it will easily go to the T wave. If this curve is lost and if it gets pointed, this is the earliest finding of ST depression. Actually, first it will get pointed, then it will start to depress like this. This we call it as horizontal depression, ST depression, and this we call it as sagging type of ST depression. Okay, these are types of ST depression, but the earliest will be there, and in diabetes, you should carefully watch this kind of sharp ST change, because in diabetes, they will have silent MI. They won't have the pain. So, in that patient also, if you are suspecting MI though, you should check for this sharpness, the J point. Okay, that should be sharp, and it should be at least 3 or 4 small boxes. That is the earliest finding of ST depression, followed by horizontal type or sagging type. Okay. Can you move forward? Yeah. So, see here. This is what you should focus on. See here. What's happening? This is the normal level. It has been depressed. Clinical implication? No. Only that clinical implication is there. That sharpening of the ST segment. You should know, because that is also a type of ST depression only. Even though it is straight, but still, since it is sharp, that is also a depression only. Okay, good. Sachin Prasad. It is ST depression followed by T wave inversions. T wave is inverted, ST is depressed. Good. This is a case of NSTEMI if cardiac biomarkers are positive. Okay. Then what happens? So actually, if you see closely, this is caused due to, I told, complete occlusion, but it is the initial stage of blockage. So initial stage of blood clot, primary hemostatic plug is formed by what? Platelets or coagulation factors. And finally, what secondary hemostatic plug is formed by what? This will be platelets plus fibrin strands. Okay, so this is the starting stage. NSTEMI is nothing but the starting stage, initial stage. Okay, so here the treatment of choice will be antiplatelets you will be giving, like aspirin, good, Karthika Shiva, aspirin, clopidogrel, as well as we will be giving low molecular weight heparin. Okay, then here platelet as well as fibrin strand is there. Fibrin would have formed just that complete clot, thick clot. So to break that, you should have that fibrinolytic agent. What is fibrinolytic agent? We see RTPA, recombinant tissue plasminogen activator. Okay, it is like tenecteplase, reteloplase will give, or we can go for stenting, percutaneous intervention. This is STEMI. So can you understand? Now this clot we call it as red thrombus. This we call it as white thrombus. Since fibrin is not formed, it is white. After fibrin forming, it is red. Now can you understand the reason why we give antiplatelets and low molecular weight to NSTEMI and why we give RTPA and PCA to STEMI? This was a question asked in AN ECG. The patient having ST depression and T-wave inversions, complaints of chest pain, ST depression, T-wave inversions they told, and what is the treatment of choice? Nothing but antiplatelets and low molecular weight heparin. Since it is formed only by the initial primary platelet plug, you should attack the platelets alone. Only if it is formed with the fibrin strands, you go and give RTPA agents. Got it? So, since the thrombus is so severe, it is a red thrombus going on, what will happen to the ST segment? See, now whole part of myocardium is injured. This dustbin has been extended. So, all will be focusing towards the dustbin only now. So, the wave is now directed towards the lead. Depolarization wave directed towards the lead. What will cause? ST elevation. So this is the reason for ST elevation. Okay, actually if you see in some cases ST elevation will be like this. Even after the height of R wave, ST elevation will be going like this. Okay, this height of R wave, even after this ST elevation goes. So this is nothing but tombstone elevation. Meaning if you don't intervene, definitely is going to deathbed. For sure. Okay, tombstone ST elevations. Okay, so how the ST elevation starts? Actually, it starts in this area only, like NSTEMI. Since it was marked here, it starts like this ST elevation, followed by a proper ST elevation. Okay, nice. So now with this ST elevation, can I say what wall of the heart is infarcted? So for this, what I should know, the basis of leads, chest leads as well as limb leads. So so actually if you see, this is the heart. Okay, this is the heart located. What happens? This is the person standing. Okay, so heart is like this. So actually in the left arm there are augmented limb leads, like left for the left arm as well as for the right arm. One lead we will keep, and for the foot we will keep one. So these are unipolar limb leads. Okay, they have only one pole. And next is lead 1, which is kept in the lateral side. Lead 2, which is in the left lower leg, and lead 3, which is here. So actually if you see, this will be, lead 1 will be at 0 degree of the axis of the heart, and lead 2 will be around 60 degree, and lead 3 will be 120 degree. And if you take these, am I audible? Am I audible now? Yes. So this forms the lateral side of the heart, and this forms the inferior part of the heart. Where am I looking at? I am looking at the inferior surface of the heart. From this leads, I am looking at the lateral surface of the heart. So lateral leads are nothing but one and AVL forms the lateral leads. I am seeing the lateral surface of the heart with 1 as well as AVL. And I am seeing the inferior surface of the heart with this 2, 3 AVF. Okay, and this is a basal portion. So you should know this: lateral leads, inferior leads. Okay, yes. So next, so that's it. Why were we discussing these things? Discussing because if ST elevation is there in lateral leads, then we call it as lateral wall is getting infarcted. So to locate the part of heart getting infarcted, we are seeing this leads, lateral leads and inferior leads. 2, 3 AVF inferior, AVL leadward lateral. Okay. So yes, so to consolidate everything, this is whatever we have shown. Whatever you see, the coronary artery is getting completely obstructed. So what has formed? First, it was ischemia was there, which was manifested by T wave inversions. Then injury started to happen. It was manifested as ST elevations, and finally this portion of the heart has become replaced by a scar tissue. So that is replaced by a Q wave. Q wave, ST elevation and T wave inversions. So what do they tell you? Q wave. Why does a Q wave needs to be formed in a ECG? First question. See, actually if you see this, in this Q wave, this area is replaced by a myocardial scar, which is a fibrous tissue. It is just like a window, like a glass. It's just like a glass, transparent glass. Whatever you, this records no electrical activity is going on here. Yeah, so it's like a transparent glass we can see. Whatever happens in the opposite side we can see and record in this lead. So what happens? See, usually this current will be going from the endocardium to the epicardium. So I am seeing this wall current. I am not seeing this wall current since it is a transparent glass. I am seeing this axis. It's going away from the lead. Can you see? If you place a lead here, this axis is going away from a lead. A depolarization vector going away from a lead. Whether it will produce a positive or negative deflection. Yes, good. It's good, Kartika Shiva. It is a negative deflection that we call it as Q wave. So what a Q wave in an ECG also represents? If Q wave is there, the injured cell has become infarcted, completely replaced by a non-contractile scar tissue. Okay, so that means that part of the heart is not working and contracting. If majority portion of the heart is replaced by the scar tissue, what will happen? The heart can't contract properly. It will result in immediate hypotension that can result in cardiac failure and death. Yeah, normally it is due to septal depolarization, but still here if you see, this is the reason, because reason for a large Q wave. Okay, yeah, so this is how I am going to say the prognosis of a patient just with seeing the Q wave and the R wave. Q wave I consider it as a something danger signal, and R wave is the king, meaning we are the kings. If we restore majority of the R waves, then that means you have done some intervention properly. We have salvaged the myocardium properly. Okay. This is our goal, to be kings, to be making R waves than Q waves. So what am I saying? See here, the deathbed Q waves. So if you see this, Q wave is like this and R wave is like this. R wave says viable myocardium and Q wave tells dead myocardium, scarred myocardium. So what is the prognosis of this patient? Number 1. And what will be the prognosis of this patient? A patient came with MI, I did stenting. After doing stenting, this was the case, and after doing stenting, this was the case. What is the prognosis in 1 and what is the prognosis in 2? Yeah, good. So 1 will be the worst prognosis since full of Q waves, deathbed. Good, Karthik Ashwa. 2 is full of R wave, which means the best prognosis. All myocardium you have salvaged. Just by seeing this ratio, you can tell how many myocardium you have salvaged. Okay, yes. So when will you call it as a pathological Q wave? See, actually you should compare. You should see the width as well as you should see the length. Good, Lina Priya. Width and length. So if you compare this, see, if Q wave, normally as Sachu Prasad told now, Q wave is due to septal depolarization. So how will I differentiate whether it is a pathological Q wave or a normal Q wave? So this is the answer. See, you should compare the height of R wave and Q wave. If it occupies 1/4, meaning 25% if it occupies means, then that is a pathological Q wave. Okay. Or if you see the width, if it is greater than 1 small square, and in length if it is greater than 3 small squares. Okay. This we call it as pathological Q wave. You can remember like 1 plus 3, 4. Meaning width is greater than 1 small square, length is greater than 3 small squares, and if it is Q and R is there, how to calculate the ratio? Nothing but 1/4, meaning 25%. Okay, this formula you can use for pathological Q wave. How to diagnose a pathological Q wave in an ECG. Okay, yes, if a pathological Q wave is there, this is an ECG of a patient and this is an ECG of another patient. So in whom you should actively intervene and do something, some intervention should be done for this patient. What patient you will choose? Whether this patient or whether this patient. Who you will take for active intervention? Patient 1, patient 2, Ganesh Kumar. Okay, good. So, if you see patient 1, Q wave is there, but ST is normal. Okay, but in patient 2, Q wave is there, but ST is elevated, meaning active injury is going on. Okay, active injury is going on. That means, what does that mean? That I should go and treat this patient. This indicates scarred myocardium. I can't replace it. That also means if ST is normal, it is a old MI. So if you just see an ECG, you can say whether the patient has had MI previously or not. This is an ECG of old MI patient. This is an ECG where active MI is going on. Here I should intervene and I should decrease this ST elevation. Got it, Karthika Shiva? This is the intervention we should do after seeing the ST segment. So whether actively it's going or not is denoted by ST change, and if it is ischemic heart disease is there, for all patients T wave change will be there, and if scar is formed, Q wave will be there. Got it? This is the basics of MI. See, So now I will say how to see a Q wave. See here, whether it's a pathological Q wave or not. It is, so we have a formula like 1 plus 3 equal to 4. Okay. So width is more than one small box. 1, 2. 2 small box Q wave. Like this is a Q wave. 1, 2. Greater than 1. First criteria fulfilled. Next, more than 3 small boxes in height. 1, 2, 3. Definitely increased. Okay. If R wave is there, where is R wave? Yeah, R wave is not there. V2, V3, V4. Okay. This itself says that it's pathological Q wave. And what should I intervene for this patient or should I leave the patient off? What I should do for this patient? Should I treat or not treat? Yes, since as STEMI is there, I should treat and reduce this ST elevations. Okay, nice. Okay, so yeah, good. Lina Priya. If posterior wall infarction is there, scar will be formed in the posterior wall. Okay, so here I will be placing chest leads like V1, V2, V3, V4, V5, V6. So if a scar tissue is there in the posterior wall of the heart, then what will be present in V1, V2 or V3? Can someone say this? Kuchwa Lakshmi, come on. If scar is present in the posterior wall of the heart, what change you can expect in V1, V2, V3? Scar is there. A scar usually produces Q waves in ECG, but it is present in the posterior wall. Q wave is negative deflection. But in the anterior wall, if you see, yes, good. If you see any tall R waves in V2, V1, V2, that indicates posterior wall MI. MI scar. Okay, you shouldn't neglect the tall R wave in V1, V2 because that might indicate a old scar is there in the posterior wall. You should know this also. Okay. Yes, good, Kartika Shiva. Nice. ST depression will be there. Nice, perfect. ST depression will be there with tall R wave. Good. Okay. Nice. So now we will go into the arteries and we will show how to localize an MI. Like how are they saying it's LAD block, LCA block, RCA block, okay, with just an ECG. Okay, nice. So this is the aorta and this is the heart. Actually, if you see LCA, left coronary artery, arises from the left coronary sinus, we will say. From here it arises and this left coronary artery has branches like one is first branch will be the LAD, left anterior descending artery, and one more branch is LCX, left circumflex artery. So this LAD artery actually gives a first branch. It runs in the anterior interventricular septum and it gives the first branch, which is a diagonal branch D1. Okay, this goes to and supplies the lateral wall, like anterolateral part, this area of the heart. Okay, then if you see septal branches are there. What does these septal branches do? Let's see this. See here. This is the branch. First was diagonal branch D1. It supplied the lateral part of the heart. So lateral part of the heart will be represented by what leads? I want the lead's name. Come on. Next, come on. Answer the lead's name here. D1. Diagonal branch. LAD. And this is the septal branches going. Septal, what is this? Bundle branches are there. Septal branch will supply the right bundle branch. Okay. And left bundle branch. So bundle of his bundle branches and Purkinje fibers are supplied by left anterior descending artery. Okay. Good. Next. So this supplies what portion of the heart? Nothing but these are the anterior portion. Okay. Good. Swalakshmi, Ganesh Kumar, AVL lead 1. And also if you compare the chest leads, V5 and V6. Okay. Next is, if you see, this supply, septal branches supply the anterior most portions of the heart. So, what chest leads will be present here? This area, what chest leads will be present? And next branches will supply this part of the heart. Wide, almost all anterior wall is supplied by this part. Yes, it is V1, V2. Mostly we will say V1, V2 and V3 will be here. V4. So V3, V4 we can take it here. Okay. Here we can take it V1 and V2. Chest leads. Then the last portion going and supplying the apical most portion of the heart. This is the apex. Okay. If you see that actually the apex is more lateral. Okay, so chest leads will be like this, V5 and V6. Apex. So this is the septal wall. This is the anterior wall. This is the lateral wall. And this is the apical wall of the heart. So it is V1, V2 corresponding to septal, V3, V4 corresponding to anterior, V5, V6 and lead 1 and AVL corresponds to D1 branch, lateral as well as apical. So if ST elevations are there in AVL, in V3, V4, then it is anterior wall MI, V1, V2 septal MI. If it is present in V5, V6 alone, it is apical MI, or if it is present in AVL 1, V5, V6, it is lateral MI. And you know the cause also for it. What blockage will cause? Water. Okay, nice. So if you have a block here, what will happen? This one function leading to ST elevations in AVL 1, V5, V6. This one function leading to ST elevations in V1, V2. This one function ST elevation V3, V4, V5, V6. Everything will be elevated. That means it is an extensive anterolateral MI. Okay. And if the block is here, below the diagonal branch, then it will be V1, V2, V3, V4 and V5 will be affected. V5, V6 will be affected. So, this AVL and this will be spared. So, this we call it as anteroseptal MI. Okay. And if the block is like this only, so we are going to divide this. Localize the blood clot. Nice. Next, so this is the left anterior descending artery. It supplies the bundle branches, Purkinje fibers, everything. Nice. Next is the left circumflex artery. What does the circumflex artery do? It arises here and winds around the lateral border of the heart and goes posteriorly. This is posterior portion of the heart. Okay. Posteriorly, actually if you see first branch, which is the marginal branch, margins meaning lateral most margin. This portion will be supplied by the marginal branch. So marginal branch means it is lateral portion of the heart. Lateral portion of the heart means what null findings will be there in AVL, lead 1, V5, V6. Then it comes posteriorly. This is the posterolateral branches. So it supplies the posterolateral part of the heart. Okay, and if you see anteriorly, this is the part. See, behind the heart, this part is supplied by this posterolateral branches. So if MI happens in this posterolateral branch, what will happen to these leads? Come on, V1, V2, V3, what will happen to this? Good, good. Karthik Shiva, V1, V2, V3, what will happen? Posterolateral MI mein ST segment will be, even in case of transmural MI. Transmural MI means all portion of MI is infarcted. ST elevation, good, but see properly, this is the posterior part of the heart. Okay, so if posterior part of the heart undergo transmural infarction, then it will be reflected as ST depression. Got it, Karthik Shiva? Good, Ganesh Kumar? Yes. ST depression will be there in V1, V2, V3. After seeing ST depression, you shouldn't say that it is a enstomy. Yeah, it is just an enstomy going on. It's not an enstomy. Okay, because whenever if you see ST depressions in V1, V2, V3, instantly you should go and put something called posterior leads. Posterior leads means V7, V8 and V9. These leads you should place on the posterior part of the heart, here. If you place it here, posterior, here you should place. Now, good, Karthika Shiva. So if it is placed though, now what will you have, what will you get it in this leads? If in posterior leads, if ST elevation is there, then that means it is a true posterior wall MI. Good, Karthika Shiva. True posterior wall MI. Got it? This is branches of LCX, how it's applied and how MI manifests. Okay, one more thing, next is RC. Before this, I'll just say one more thing. Good, Rina Priya. I'll say one more thing. You should know ST elevations will be there in the leads which are facing the MI, and the leads which are in the exactly opposite side, ST reciprocal ST depressions will be there. So how to remember that? See, what is exactly opposite to AVL? See this? Lead 3. So if ST elevation is there in lead AVL, then ST depression must be there in lead 3. That is the diagnosis of MI. If ST elevation is there in one lead, reciprocal ST depression should be there in the opposite lead. And if AVL, if it is ST elevation is there, then also AVL lead 1 opposite is lead 3. ST depression should be there. So actually, we can just remember like this. Like a small mnemonic called tail. Okay, this is for lateral leads, this is for inferior leads, this is for anterior leads, this is for posterior leads. If ST elevation is there in the lateral leads like 1 AVL, V5, V6, then ST depression should be there in 2, 3 AVF. Or if ST elevation is there in 2, 3 AVF, then reciprocal ST depression should be there in 1 AVL, V5, V6. Got it? Only if it is there, then you should diagnose it as MI. Okay, at the same time, anterior leads will be V1, V2, V3 and all. Posterior leads will be V7, V8, V9. This we have seen. ST elevation is there in these leads, ST depression should be there in these leads. Okay? You can remember like this. what are the leads to look for? Reciprocal inversions. Nice. So, yes, that's it. Now we will see the branches of RCA, right coronary artery. It arises from the right coronary sinus. It arises and gives branches for SA node and AV node. See, AV node is actually, I will say about AV node later. SA node is supplies first, that is a nodal artery. Then it comes and supply the right ventricle. Right ventricle is supplied. So what are the leads facing here? Chest leads, V1 and V2. At the same time, it supplies this part, which is the inferior wall. Yes, good. Inferior wall, which is 2-3 AVF. Okay, nice. So this thing you should know. So RCA, what it does? A branch of RCA actually circumflexes, goes to the posterior side of the heart, gives a branch called branch in the interventricular septum in the posterior side, which is posterior interventricular artery. Just note this: the artery giving this branch, posterior interventricular artery, and this posterior interventricular artery actually supplies the posterior 1/3 of the interventricular septum, as well as this artery gives and supplies the AV node. So posterior ventricular artery supplies the posterior part of 1/3 of interventricular septum. AV node it also supplies, and it supplies the posterolateral, this part of that. Posterolateral was supplied by LCX. This will supply the posterior medial part of the heart. Okay, posterior medial. This you should know. So, whenever an artery giving posterior interventricular artery which supplies in interventricular septum, AV node and posterior medial part of the heart, this whatever artery gives the branch, that dominance we will say. If it is a branch from right coronary artery, we call it as right cardiac dominance. And if it is left coronary artery, left circumflex artery, this can also, in very few patients, this can also give this posterior interventricular artery. If this gives a branch LCX, then it is left dominance, left coronary dominance. Actually, 85% of the cases will have right dominance, and 5 to 10 will have left dominance, and some patients will have both. This PIVA will be branched from both. So that is we call it as codominance. Okay, it's a dominance of the heart. So here you should know one more thing. It supplies SA node and AV node. So heart blocks like complete heart block and sinus bradycardia can be seen in this RCA blockade. Okay. Nice. So complete heart block is seen in a patient and it is an inferior wall MI. If it is an anterior wall MI. Okay, first question is, inferior wall MI is caused due to what artery blockade, what coronary artery blockade, and anterior wall MI is due to what coronary artery blockade. Start answering. Yeah, good. Inferior wall MI will be RCA blockade, anterior wall MI will be left anterior descending artery blockade. So, how to treat this? See this? If complete heart block, why complete heart block occurs? Because RCA supplies AV node, and if it is blocked, then it will result in complete heart block. And if LAD can also cause complete heart block. How? Since it supplies the bundle of his Purkinje and bundle branches. If this is blocked also, it is complete heart block. So here what you should do is, since AV node is the culprit, you can actually just do stenting. Since AV node is the only culprit, it will recover. But here, stenting also you should do. At the same time, you should give pacemaker, artificial pacing also you should do. Because pacing means because all these are affected. So what you will do? You will put electrical electrodes in the heart here, and you will give current from an external pacemaker. Okay, that will give current and stimulate the heart. So if LBB is congenital block, umbilical block is due to anterior wall MI, should do stenting as well as pacing, and if it is due to inferior wall MI, only stenting can relieve the heart block. Got it? Yes. Good, Kartika Shiva. So here, just see here what is going on. Where is ST elevations are seen in where and ST depressions are seen in where. What is the diagnosis of this patient? ST elevations are there in okay. Yeah, ST elevations are there in V2, V3, sorry, lead 2, 3 AVF, and ST depressions are there in here. ST elevation is there, ST elevation is there, ST elevation is there. Good. So this is inferior lead ST elevation. So actually if you see, that is pale visona. In lateral leads you should have ST depression. What are the lateral leads? 1 AVL, V5, V6. Yes, good, Kartika Shiva. 1 AVL if you see here, ST depression, here ST depression, and V5, V6 also we can see ST depression. V5 you can see, okay. So this actually is an MI, and also it is an inferior wall MI. This is the diagnosis. That too ST MI. Good. So yes, let's go further. Let's go for the definition of MI. So as we told, essential criteria will be what should be positive? Cardiac biomarker. That too, what I told as most specific, it is troponins. Cardiac troponins should be positive. If it is positive, it is definitely MI, treated as a MI. Okay, and with troponins, we should have any one of the finding. Like, sorry, if troponin is positive, then you should have any one of this finding, then you can treat as MI. What are the findings? Clinical criteria, like the patient is having typical kind of anginal chest pain. Okay, anginal chest pain like it is present in the leftmost region. It is radiating to the epigastrium, neck, as well as to the left hand, left upper limb, as well as variatal shoulders. It can radiate. Okay, all these radiations are there. Then it is troponin is positive and clinical features. You can immediately go for treatment like MI. and ECG changes are there, like ST elevations are there, or Q wave is there, T wave changes are there, then you can go for treatment like MI. Or if you do echo may there is all part of the heart is contracting except this part. This part is not called functional, it can't contract. So this regional wall is not moving, so it is called regional wall motion abnormalities, RWMA. No, cold spot it won't be seen here, it is seen there. See, RWMA will be seen in echocardiography. And technetium scan, this perfusion scan, it will go where and all the blood flow is there to the heart, functional myocardium it will go, and it won't go to the dead myocardium. So this portion will appear as a cold spot in technetium scans. Or after death, how can you demonstrate MI? If you demonstrate a clot in the coronary artery, it's like MI. Okay, so these are diagnostic criteria of MI. Either troponin should be positive with any clinical finding like angina chest pain, ECG findings, echo findings, as well as technetium scan finding or post-mortem biopsy. Okay, this is essential criteria for diagnosis of MI. Okay, so here comes the diagnostic dilemmas. Now you people should answer what you should do in such cases. See, if troponins or troponins T or I is positive, okay, then ECG is normal. What you will do for this patient? This will occur in clinics. What will you do for the patient? If troponins is positive, ECG is normal, then what you will do? Echo is normal, then what you will do? Patient comes with severe, so patient comes with troponins positivity, and ECG is normal. What you will do? Will you treat him like MI, or what are you going to do for this patient? Treat for MI. Okay, why? We saw the essential criteria. Troponins positivity should be there. You should look for clinical findings. How it is looking for clinically? If clinical finding is there, then as Kartika told, you can treat like MI. Like you can give the loading dose, everything. Loading dose is not a problem. You can give for any patient with chest pain, it won't cause any problem. But still, you should give loading dose and start treating the patient as MI. But if clinical feature is negative, ECG is normal, then he doesn't need any treatment. But he should be observed and ECG should be repeated. Serial ECG should be done for this patient. Repetition of ECG to look for any changes. Since troponin is positive, should repeat the ECG and look for any changes. Okay. Then next is, if echo is normal, it's actually not a criteria, because echo will happen only in the advanced stage. So echo is normal also. You should see the ECG. Serial ECG must be done. Clinical features you should be seen. It's negative. If ECG is normal, then you get discharged. So in these kind of patients, you should observe. That's the point. Observe, do serial ECGs, look for clinical features. Okay, this is the option. Then, if troponin is normal, that means it is negative. Troponin is negative. ECG showed ST elevation. What will you do for this patient? Come on, start answering. If ECG has shown ST elevation, what you will do? And troponin is negative. And STEMI treat. ST elevation is there. It's a STEMI. Okay. So treat. Good. Your answer is right. You should treat him as STEMI. Why? The reason I will tell. Because if you see the troponins, it takes, since the onset of chest pain, it takes at least 4 to 6 hours to develop positivity of troponins. Okay, and it stays in the blood for at least 10 to 14 days. So in this patient, ST elevation has happened at this period. So, won't you treat? Good. So, what you should do in such patients, what you can do after some time, what you can repeat, what test can be repeated after some time at this stage. What test can be repeated? Good, Kartikeshwa. Troponins must be repeated after 3 to 6 hours. Now do you understand what is the reason behind they saying 3 to 6 hours? Because it takes at least 4 to 6 hours to become positivity. So you should repeat after 3 to 6 hours. Definitely it will become positive. Treat like STEMI. Okay. If no ST changes are there, then what you will do? Clinical, so troponins is negative. No ST changes also. Here, you should observe for clinical findings. Chest pain is there or not. If it is not there, no need to treat. Just observe. Okay. That's it. Next. Echo findings showed regional motion abnormality. Troponin is negative. What you should do? This means you should treat or not? Treat like ST elevation MI. Because if RWMA is going on means that blockage is that acute that even before 4 to 6 hours RWMA is seen, which means that acute severe obstruction is going on. So definitely you should treat, and you should do repeat troponins after 3 to 6 hours. Okay. Yes. Next, so this is the importance of knowing these values. Actually, when I was studying also, it was very irritating for me to know the time period when it elevates, when it gets settled. But you should know these things only. Then you can know why they are repeating troponins after 3 to 6 hours. What is the need for them to do? If ST elevation is there, why are they treating as STMA? Why is troponin not getting positive within 4 to 6 hours? This is the reason. Simply understanding this curve, we can actually take decisions what to do. You can understand the diagnostic dilemmas which comes in case of MA. Actually, I think one question also came from this dilemma in AN ECG. Okay, so it's actually clinically also it will be helpful to treat myocardial infarction. Next, so next is with this curve, can I say some more information? See, if the patient has undergone an infarction and after some 2-3 days again he is complaining of severe chest pain, which means the patient might have reinfarction. So after some 2 to 3 days at this time, if he develops reinfarction, how will I identify it? Troponins will always come positive. How will I identify this? And if the patient develops after 10 to 14 days, How will you identify it? This though it is understandable. Now no troponins will be there. So just measure the troponins. If it is positive, then it is definitely reinfarction. See this. If it is again positive after 10 days, it is definitely reinfarction. But if it is less than 10 days though, what you should do? You should measure the level of troponins previously as well as new levels. You should measure this difference. Okay. Previously, if it is some 40, then actually from that it should have elevated, like greater than 20 to 25% it should be elevated from the previous value. Usually troponin trend is falling trend only, but if it is in the increasing trend, that too greater than 20, some say that 25%, if it is in that trend, then it is reinfarction. So now, can you understand, with just one simple curve of troponins, we have diagnosed reinfarctions thing, and we have seen why they have been repeated after 3 to 6 hours, and what is the need for troponins to become positive. So that's why they are included in the essential criteria of MI. This is the must criteria. This must be there in MI. Okay. Okay. So what are the timing deficiency in MI? Like, if a patient comes to you with NSTEMI, I told, NSTEMI is just antiplatelets, and we will give atorvastatins, we will give, and dual antiplatelet we will give. Dual meaning aspirin, clopidogrel, ticagrelor, everything. Statins as well as low molecular weight heparin. ST elevations, what you will do? Yeah, this is the timing decision you should take. If you find ST elevation in a patient, how will you approach? If it is a PCI capable facility, like if it can do percutaneous intervention, coronary intervention, then what you should do? Send the patient instantly. Don't think of anything else, because stenting can absolutely recover that blocked coronary artery. Okay, so it should be done instantly. At least ideal time is, if it is sent within like 90 minutes, it is ideal, but it can be done till 24 hours, which means 1 day. Okay, and next scenario, if patient has STEMI, and if it is not a PCI capable area, like it might be like a PHC or simple clinic, in that patient comes with ST elevation changes. Now what you will do? You should look whether the patient time for shifting. If it is less than only 2 hours for shifting, then send the patient. It's better for the patient. Let the patient go on survive with stenting. Or the patient is in shock. BP is in greater than 90. Sorry, less than 90. Systolic BP less than 90. So here, what does this mean? When will the patient goes for a shock? Only when left artery descending artery or main artery is blocked so much that so much of the heart is infarcted that heart can contract. So it is just a scary heart. It can't contract, leading to hypotension. So in such kind of patients, what you will do? We can't salvage this patient with injecting fibrinolysis. Should introduce stenting and you should remove that block. So definitely, if the patient is in shock, whatever the time may take, send him for stenting. You can't salvage in a PCI capable area. If the patient is in shock is not there, and delay, you think like delays, it takes more than 2 hours to go for a PCI capable area, only in this condition, you should go for thrombolytic agents, fibrinolytic agents. Okay, fibrinolytic agents like retinol tenecteplase, place, everything. So ideal time is 30 minutes. If it is done ideally though, you can salvage maximum of myocardium, but can be done till 6 hours. Actually, since in India, PCA incapable facilities are more, they have liberalized this criteria to at least 12 hours. So 6 to 12 hours can be done till 12 hours. Okay. So you can remember like this is half a day can be done till this is 1 day. This is 30 minutes ideal. This is ideal 90 minutes. Okay. This timing decision for MI. So complication will be acute complication in PCA will be bleeding. Like they will introduce a catheter into the artery so that local bleeding will be there. Like arterial bleeding. Chronic, what will happen? The stent is placed in the artery. In this stent, what might grow? Some atheromatous plaque or this endothelial cells will grow more. They tell it as neointima. New intimal cells, intimal proliferation will happen and it will block the stent also chronically. So that is restenosis. Okay, this is chronic. This is acute. Okay. So only stents are coated with what? Tacrolimus, sirolimus we will coat because these are anti-proliferative agents. This will inhibit the neoproliferative. Okay. Then with fibrinolysis, most common complication will be bleeding elsewhere. Anywhere it can bleed because fibrin is getting damaged anywhere in the body. So yes, this you should know when you should go for percutaneous interventions. When you should go for percutaneous interventions. When you shouldn't go, contraindications. So see, if a big stout clot is present in the left main trunk. What is this? Left main trunk. Meaning even above the bifurcation of LCX and LAD. Big stout clot is there means then your stent can't go into that blocked area. There you can't do PCA. And if the patient has all the three vessels are involved by complete clots are there in all three vessels, then it is called as triple vessel disease. And diabetes. In these conditions, triple vessel disease, diabetes, left main artery clot, this you can't go for stenting, you should go for CABG. Coronary angio artery bypass grafting. A graft should be clipped here to here. Okay. So this is indication for CABG. This becomes an indication for CABG. And this is also the contraindication for percutaneous intervention. Okay. So that's it. We have seen everything. I'll just quickly recap and then we'll end the session. So what all we saw? Were you able to understand? Is anything to be repeated? Is anything to be repeated? Do you understand? Okay. Now we will have a quick recap of what happened, what all we saw today. First we saw ischemia, we saw in previous video. Injury we saw. Injury mein what happens? The necrotic cells having a local hyperkalemia, so they are having tall T waves. Tall T waves we saw how to differentiate from hyperkalemia with QT interval as well as you should see with cardiac biomarkers and serum electrolytes. Tall T waves was pointed and narrow in hyperkalemia and broad and blunt in MI. Then we saw the necrotic cells releasing LDH1 more than LDH2. So it's a LDH flip mechanism happening we saw. Then we saw CPKMB is released into circulation troponins are released. Most specific is troponin I, but most commonly done test is troponin T. And troponin T is excreted by the kidney. So in CKD diabetic nephropathy patients, you can't do troponin T. Troponin I should be done in these patients. Then we saw how this injured area has becomes a dustbin for every ions to enter continuously into the cells, leading to production of, if it is subendocardial ischemia, it was producing ST depressions, and ST depressions, it is due to initial is just to do primary plated plug formation. It is NSTEMI if cardiac biomarkers are positive. If it is negative, we call it as unstable angina. Treatment of choice will be primary plated plug, so we will give antiplatelet with low molecular weight apparent. Next, if it so types of ST depression we saw earliest will be the sharpening of the point in that in diabetic. Then horizontal sagging and horizontal ST segment depression we saw. Then complete blockage, transmural MA or ST elevation we saw, leading to ST elevations in the leads facing the MA. So severe thrombus, the red thrombus, so you're giving fibrinolytic clots as well as stenting. So this is a tombstone ST elevation also we saw. Then axis of MA we saw lateral leads, AVL lead 1 and inferior leads lead 2, lead 3, AVF. So then we saw why Q wave is formed and what is the reason for Q wave and R wave. R wave is king, whatever salvageable myocardium is R wave, whatever dead myocardium is Q wave. So we predicted the prognosis with the help of this thing. Then we saw whether MA is active or not. Q wave, pathological Q wave we saw 1 plus 3 is equal to 1 by 4 we saw. So width is 1 small square, height is more than 3 small square, and if it compared with R, if it is greater than 25%, then it is called pathological Q wave. Then we saw whether if it is associated with ST elevation, it is active MA going on, entering the patient. If it is no ST elevation, then it is old MA, scarred, old myocardium. We can say whether the MA has happened in the past or not. Then we saw posterior wall MA will be reflecting as Q waves there, will be reflected as R waves in the V2, V3, V4. And if it is associated with ST depression, then we suspect posterior wall infarction. There we should also keep posterior leads. Then we saw the branches LAD, L6, everything. So in LAD, first branch was diagonal branch, which was supplying the lateral part. So 1 AV and V5, V6. Then was septal branches supplying the bundle branches, and next branch was supplying the anterior wall of the heart V3, V4. Then went to the apex V5, V6. So lateral, septal, anterior, and apical wall are supplied by LAD, and it also supplies 2/3 of interventricular septum. Okay, and it also supplies bundle of branches, Purkinje fibers, as well as bundle of his. Next, L6 we saw a branch which supplies the lateral most portion of the part with the marginal branch, and posterior lateral branch which supplies the posterior part of the heart. So that will be reflected as ST depressions in V1, V2, V3. Then pain we saw. With this mnemonic, you can remember if ST elevation is there in the inferior lead, then reciprocal will be in the lateral leads. So this is vice versa. At the same time, posterior and anterior, vice versa. Then we saw a branch of RCA, SN artery as well as posterior interventricular artery, which runs in the posterior interventricular septum, which supplies AV node, posterior 1/3 of interventricular septum, as well as posterior medial part of the heart. If it is a branch, if posterior interventricular artery is a branch of RCA, then we call it as right coronary dominance, which is most common, 85% individuals. If it is a branch of LCX, we call it as left coronary dominance, and if it is both, we call it as codominance. Then we see CHB due to inferior MA, we will just treat because AV node is the only culprit. But this anterior MA, everything will be affected, so we can't treat this patient, so we should go for pacing. Then we went for MA definition, we saw cardiac markers should be positive along with clinical features or ECG or echo or technician scan. If the patient is dead, postmortem biopsy, we should see the clot in the coronary artery. Then we saw the diagnostic dilemmas, different dilemmas, what all can possible and how to approach the patients, and troponin levels rise and fall, how do that implicate in clinical settings. Okay, how to take decisions and how to diagnose reinfarction. Then we saw timing decisions in STEMI. If it is PCA capable means only PCA, not capable means we should see whether BP is stable or not. BP is stable, if delay greater than 2 hours becomes an indication for fibrinolytic agents. Then if it not, then consider the patient for PCA. Ideal time we saw, I have 90 minutes, 30 minutes. One day can be done till 1 day, can be done till half a day, like 6 to 12 hours. Then we saw the agents, most common complications we saw, and we see contraindications is left main artery where there will be a big clot blocking, and or it's a triple vessel disease with diabetes. So all these becomes an indication for coronary artery bypass grafting. Okay, that's it. Hope you enjoyed. Anyone having any doubts? Can we wind up the class? Okay.